We're good? We're good to get going? Okay, so some of you know me, some of you may not know me. I'm Joe Basha, and with me today I have Jeff Keel and Patrick O'Toole. You'll see a lot more of them than you probably will see of me. However, every once in a while you will. They dust me off and they let me come do something now and again. So we're here to talk about ECMO therapy. Everybody here, I'm assuming, has prior ICU experience of various different years, but just so that I know what your experience level is, how many here have firsthand experience managing ECMO patients? So a pretty good portion of you, at least a third. That's terrific. So you all know that sometimes when you hear, I think we're going to go ahead and put this patient on ECMO, this is the look that we usually see, right? It's like, oh no, please. But I want you to not fear. Let's see, we have some other folks coming. All righty. All right. Welcome everybody. Come on, crowd in. Don't be sitting way back there. Come over here. You know what? Y'all are come on over here. I like to have you closer to me. It feels better. Come on, there's all over here. All right, cool. So we're talking about, for those who just walked in, sorry about starting early. I apologize for that. We were talking about ECMO therapy. This is commonly the face that you all will give the physician when he tells you, call the perfusionist or whatever, we're going to put this patient on ECMO. But I want you to not fear, because your HET perfusion staff is here to help you. This is Joe, that's Jeff, and that's Patrick. So why are we even really talking about this? Well, at the end of the day, ECMO is here to stay. It's not only here to stay, but if you look at this report written from 2006 to 2011, there was a 433% increase in the utilization of ECMO therapy in the United States. Of course, who gets it? Adults, pediatrics. So pediatrics hold everything. We're not going to be talking much about that, but obviously they are a huge consumer of ECMO therapy. Adults, you have the VV for ARDS, pneumonia, the H1N1 problem, aspiration pneumonia, sepsis, and of course VA for patients who have basically heart failure. Generally speaking, they need full circulatory support and frequently cardiopulmonary support. Their lungs are trashed as well. But I think this trend has continued to grow, and that this is not just from 2006 to 2011. I think if we get the numbers, once we have them from 2011 to 2016, 17, I think you're going to see that number increasing even more. So that's the trend line. So where is ECMO done? Well, it's done in many hospitals do ECMO. They do ECMO in the ICU. Of course, we do ECMO in the operating room. We had pilot projects here in Houston at a hospital with ECMO in the emergency department for patients who came in with refractory lethal arrhythmias on the thumper, and they were putting the patients on ECMO. That's done at Scripps, not just done here in Houston. It's done in a couple of other places around the country, and there's some really good, very heartstring pulling videos online where these patients were put on ECMO as soon as they hit the emergency department coming from the field. Now, all of us here are familiar with the golden hour, right? Anybody here military? So the golden hour is the time it takes to get a soldier from their injury to treatment. And if they can do that within an hour, their chances of surviving that injury are much greater than if it's a delayed transport for that particular person. We're all here very familiar with time to cath lab, time to PTCA, opening the vessel. The sooner you can get that vessel open, the more heart muscle you're going to preserve. So all of these metrics are kind of measured. Well, it's kind of been figured out that, well, patient needs full circulatory support. The sooner we can get them on ECMO, the better will be their chances of survival. So this is in France. They have a program going on right now where there is a physician who has been trained in cannula insertion in the ambulances out in the field in the emergency vehicles. And over here in the top left-hand corner, they are putting the patient on ECMO in the subway. Over here is at the Louvre. This was the first one that they did. Over here, it's on a street, and over there, it's even in a supermarket. As we speak, the University of Michigan is embarking on a pilot project that will mimic this. There is a physician or group of physicians that have been trained on percutaneous insertion of cannulas in the femoral route, typically, on the ambulance, ready to go in the field and put a patient on ECMO wherever it may occur, somewhere up in the Detroit area, or Ann Arbor area, as it's going to occur. And it is why I said earlier, there's no question in my mind ECMO utilization is going to continue to grow in this country. So some of the things we're going to talk about today are indications for ECMO, general definition of ECMO, categories of ECMO, cannulation, complications, weaning, how do we wean, survival, and some financial data. Look, I'm just going to tell you, I could stand here for 3 days and never cover all of the topics. This is going to be a fairly rudimentary, but I try to get into some stuff, talk. But to really be able to do ECMO, to understand ECMO, you really need to go to a course, which I would think no less than 5 days at a minimum. Now, of course, I trained, at the University of Arizona for years to do this. Jeff, same thing. I think he went to Texas Heart Institute. Patrick, I'm not sure, where did you go? Rush Presbyterian. He went to Rush Presbyterian up in Pittsburgh, and they have a huge ECMO program up there. And I've been practicing for, plus or minus 38 years. Jeff about 25 to 28 years, and Patrick about 15 years. So we've done this a long time. To us, it's ECMO. We go downstairs and put the patients on bypass every day. It's just a miniature version of it to us. But the patients are very unique. They're very different. There's a lot of variations. It's not just a miniature heart-lung machine. A lot of different stuff happens. We're going to try to get into some of it, but understand that I'm not here to make you all ECMO experts. I'm really here to try to take away some of the fiction from fact or fact from fiction so you kind of understand the fundamentals of it and then what to expect from us when you guys do get confronted with these cases or these patients, because you will be confronted with them. And if you have a question, just raise your hand and ask a question if I'm going along here. You interrupt me anytime you want. So ECMO is a temporary therapy used to provide cardiac or respiratory support, or both, full cardiopulmonary support. It does not fix anything. It buys you time to fix it. And ECMO therapy, it says here, is designed for 3 to 10 days of support. That's depending on the circumstances. So let's sort of back up. You have a patient who has pulmonary failure, pure just pulmonary failure. Their lungs aren't working, heart working fine. We put them on VV ECMO, and all we're going to do is oxygenate for that patient. That's not going to obviously fix the problem, the underlying problem. It's just going to keep that patient alive for the problem to get fixed if it's fixable. And we'll talk a little bit about survival data, because that's also something. There's a lot of people. How many people here feel that ECMO, the survival of ECMO is 10% or less? 20% or less? 50-50? It's interesting. That's a very interesting demographic. I'm going to show you some stuff about that. But it says here designed for 3 to 10 days of support. That's going to be more or less in our circumstance. If you're a lung transplant patient and you're waiting for your transplant and you need ECMO, they actually put these patients on ECMO, connect it to an IV pole, a little different than the system you're going to see today, and they walk around and exercise with it so that they don't just lay in a bed waiting for their operation, waiting for their surgery. They keep them basically healthy. They exercise them, they keep their nutrition up, and so forth. But those patients generally have lived with their condition for a long time, so it's not an acute event. So we put them on ECMO, they exercise, that could be 2 months that they're on ECMO. So ECMO doesn't have necessarily this 3 to 10 days and we've got to turn it off. But there are different kinds of ECMO. You have ECMO for that, bridge to transplant. That can also be VA. Now, they're not walking around on VA. It's a little bit different. Usually, you're going to use some kind of device like a HeartMate or something like that. But you've got basically bridge to decision, bridge to transplant, and destination therapy. So bridge to decision is really what we're looking at. So we'll get to that one last. Bridge to transplant are those patients that I'm talking about. They need a device to basically keep them alive until they can get a transplant. Destination therapy is you're getting this device and that's all you're going to get. You're going to live with the battery pack and you're going to go to Walmart and you're not going to have a pulse because they're all centrifugal now. None of them have a pulse anymore. And you're just going to live with it until something happens to the device or you just die from other causes. And then there's the bridge to decision. Patient is acutely ill. They have either pulmonary or cardiopulmonary or just cardiac decompensation. They need circulatory support or circulatory pulmonary or variation of it, and that's all they need. So the 3 to 10 days is what we're looking at here, although we've had them in for 3 weeks locally, but within that time frame, if this patient's going to recover or if they're going to continue to decompensate. They usually fall apart from other reasons, whether it be just hemorrhage or they go into liver failure or they have some other, bowel ischemia. There's other things that generally happen. So this is basically the ECMO circuit. And as I said, it's a modification of the full cardiopulmonary bypass circuit. And that's what you see over there on the right. Don't spend a lot of time looking at that diagram, but basically that's the schematic of what the pump looks like downstairs that we run. And this is what that pump looks like in reality. It's a little bit older version, but what I want you to focus on is this piece right here. And that's a reservoir. Now, those patients that are having heart surgery, we give them 30,000, 40,000, 50,000 units of heparin. They're fully anticoagulated. And of course, there's pump suckers and there's all this stuff. But we can use that reservoir to control the patient's volume. So we can slow the pump down or increase the vacuum, the amount of force we have draining the right atrium and fill that reservoir up and completely collapse the heart. That heart is flat. There's nothing in it while they're doing these procedures. Obviously, that's not going to be the case with ECMO, and I'll kind of get into that. But there's some of this stuff that about a regular heart-lung machine. In contrast, you have the ECMO circuit. And once I'm done with this talk, Jeff and Patrick are going to take that pack that's sitting on the floor right there, set this up just like we would if we were here getting ready to do a procedure. And I think that the hospital has decided, and I'll have to talk with Pablo about this, I believe, we're going to have this thing set up and ready. It'll last for 30 days, set up, covered up, a tag on it that says it was set up by whom, at what time, and then every 30 days we'll change that circuit out. It'll have everything ready to go, and I'll show you this later, but we have these cards, and these cards are designed, if you follow each one of these steps with it already pre-set up, you would be able to prime it, because what can happen is they want the ECMO, they want it now, and we're on I-45, and a truck just ran into us, or we just can't get through the traffic. We could be across the street and not be able to get here. So you guys have to at least have some feel for it. And I think once you see it and it's set up and how we're going to leave it for you and how this works, which Jeff and Patrick will do later, I think you'll feel a lot more comfortable with it at the end of the day, because we may need your help. We can't do this all by ourselves. It's just impossible. And then, of course, with the increase of ECMO utilization, what if we had an epidemic, something worse than H1N1? There's a limited supply of perfusionists. There's 4,135 perfusionists in the entirety of North America. That's the United States, Canada, and Mexico. That is not very many of us. So it's very easy to see where, not obviously Ebola, but an Ebola-like outbreak where you had just masses of people going on ECMO would run out of us. So I think we need to start this conversation now and start a process of getting you guys much more comfortable with it, because anything can happen. It's just a reality. Anyway, there's the circuit. That's what it looks like set up. The oxygenator's over on the right. The centrifugal pump is on the right towards the bottom. It's got a priming bag up towards the top, and there's a flow meter or a gas blender up on the top that can blend the oxygen from 100% down to 21%. It has flow, and that's kind of synonymous to the FiO2 and either the rate or the tidal volume on your ventilator, the sweep gas, basically we call it. And then a control monitor, a battery, and that's pretty much it. So contrasting that, what you see here, to this, you can see that it's got a lot of similarities in necessarily what it does, but it's very different. Venous blood is drained by kinetic assist, so when the centrifugal pump is spinning, it's pulling the blood out of the patient, and then it goes from there into the oxygenator, and that one outlet continues to flow up to the return, wherever that return may be, and we'll talk about all those cannulations. But the major difference is that you can't modify the volume of the patient because it's a closed system, so you don't have that reservoir anymore. So if the patient is hypovolemic, then this thing will start to chatter. The drain coming from the patient, usually the venous access, will just start shaking and chattering. And you got to fill the patient up, because that is the reservoir, is the patient. If the patient is hypervolemic, they've been just volume overloaded from massive transfusions or whatever the case may be, you have to use another mechanism in order to get that volume out of the patient. We'll talk about that a little further. I can't just simply increase the volume in the reservoir because I don't have one. It's a closed loop system. What comes out is simultaneously going back in. So we don't alter the volume of the patient at all. And then when we go on, it's primed, so the volume stays essentially the same. It's a euvolemic situation. Categories of ECMO, there's veno-arterial, of course. This is for supporting the heart and the lungs simultaneously. It's basically full cardiopulmonary bypass, and it's just a miniature form. This ECMO circuit does affect hemodynamics and gas exchange. There's veno-venous, which is just for supporting the lungs only. There's no hemodynamic support. But that also can be a little bit of a gray area. It depends on your cannulation. If you're cannulated in the femoral vein, and the cannula goes all the way up to the right atrium, and that's your access, you pull it out, and you put it back into the right internal jugular, then that is veno-venous bypass. So you're basically, or ECMO, taking the blood out, oxygenating it, pumping it back in, it fills the right atrium with oxygenated blood, and it makes its way through the circuit. Now there's levels of recirculation that occur in that, and it's not perfect, it's not pure. So you're not necessarily, you're gonna have some of that blood shoot right down through the atrium, and it's going to get picked right back up by the access cannula and go in a big circle. So that recirculation's pretty high with that cannulation technique, probably up to 50%. I would say 40% on average. So your efficiency is decreased by 40%, maybe 50% when you cannulate that way. But sometimes it's an easy, quick way to do it, depending on the level of support the patient needs. The other way to do it is you put the short venous cannula in, and then on the contralateral side, put the long one in, and you drain out of the short one and return to the long one. So the natural blood flow, of course, is that direction. You're taking from below and returning above. Your recirculation is a little bit less. But it's a little bit more tricky to cannulate that way. Now, the third way of doing it is this Avalon catheter. And this is a 31 French, and that long piece there is just the stylet, so I could pull that out so it doesn't quite look so ominous. There. Take that, that's just for insertion. But that's it right there. And it goes in the right IJ, it goes down, and this tip, it's big, isn't it? Behave yourself. Behave yourself, okay? We have devices. So this tip sits in the inferior vena cava. This piece up here, if you can see it, sits in the superior vena cava, and this sits in the right atrium, angled towards the tricuspid valve. So how it works is it's a single dual stage cannula. So it pulls from here, and returns here, all from the same cannula, kind of like a Maherker catheter, only bigger. And that jet that shoots down, if you orient it properly, through the tricuspid valve reduces tremendously the recirculation I talked about from that other technique. And it's only one thing you need to stick in somebody, not two. And I know it looks big, but this isn't the biggest one. This is actually kind of a mid-size. So the IJ can take a big tube. It's really surprising how veins just much more distensible, clearly. So that's what that looks like there. But the fourth thing that you can do is, what if you had a cannula that actually went into the pulmonary artery and it drained from the right atrium and returned it to the pulmonary artery? Such things exist, but we have to be somewhat realistic. If you had that cannula, however, you could actually bypass the right ventricle. So if you had some RV dysfunction, you would have no recirculation. It would be the most efficient cannula you ever use. The dual cannulation technique, cannulas are going to cost you in the neighborhood of $600. This cannula, not including the insertion kits, $2,500. That cannula that I was telling you about, $16,000. So, unfortunately, we're living in a time when technology is advancing incredibly, while the ability for institutions, whether it's this one or any other one's ability to pay that kind of money, is on the decline. So it's the curves are going the wrong way, and that's clearly a problem. But those are things that do exist, and ECMO is not just what you will see. It's not just how we do it. There's all kinds of different ways it gets done, all of which some of them are better than others. It depends on your philosophy. We're going to talk a little bit about that. Depends on who's doing it, your experience level. And whether you have a robust ECMO program and you do a whole bunch of it, or you just do it every once in a while and you're really just getting them stabilized to ship them out. Everything is going to be different how you decide to build your program. But keep in mind, I would highly suggest you look at the resources that exist for ECMO, because you'll learn a lot. We can only show you so much. We can show you our way, but there are other ways, and some of them may have some better things. I'd like to learn that. What are the indications? Now, this is critical. This is very important. If you have respiratory failure, ECMO should be considered when the risk of mortality is 50%. It is clearly indicated when the risk of mortality is 80% or greater. So you can consider it, and if you did it, you shouldn't be criticized. But when it's 80% or greater, you should do it, because predictably this patient's going to die. This is published data, so this is something that you can say exists as evidence-based medicine. 50% mortality risk is associated when you have a less than 150 PaO2 on ventilator with an FiO2 of greater than 90%. So when you have a patient that is this, then you are in the area of you should be considering this. When you have this, then you have advanced to the point of it is clearly indicated. So here is your clinical situation, and based on these clinical criteria, you should be either considering or it is clearly indicated and you should do it. Now, if you don't do it, it's a 95-year-old and they meet the criteria, should we put the patient on ECMO? No, shouldn't. But if they're 45 years old and they're a fireman and they rescued somebody from a burning building and have severe smoke inhalation and ARDS, well, hell yeah, we should do it, of course. And then there's everybody in between. VA ECMO, you can read all that. VA ECMO, the heart ain't working. Can't support their circulatory system. And you need to do something. So VA ECMO, cannulation for that is another very complex issue. Let me get to this slide. So if you have peripheral cannulation like we saw in those pictures, and the heart kind of recovers, so you're taking femoral vein, putting it in femoral artery, and it's purely cardiac, no lung involvement whatsoever, you can get away with that for a pretty good long while. However, when you do VA ECMO with peripheral cannulation, you increase significantly the afterload on the heart. So you're going to increase the left ventricular wall tension, make it more difficult to perfuse an already sick heart. Now, rescue therapy, yeah, you got to do that. But when you leave it like that for extended periods of time, that heart just gets weaker and weaker and weaker and more dilated, and it doesn't work very well after that. Now, alternatively, you can do that, and then you can put an impella in and put in basically a left ventricular vent, and you can put that through the subclavian and basically create your additional cardiac output that way to keep the left heart decompressed, which is going to make it a lot better. A lot of people do it. A lot of people have good success with it. That works. They have the transseptal approach, where you put another cannula in, made by the company Cardiac Assist, and that becomes your left ventricular vent. But they have to put that in the cath lab, so you have to transport the patient, put it in under fluoro, go through the intraatrial septum into the left atrium, and you decompress the left side of the heart that way. Alternatively, you can put your access cannula in the femoral vein, you can put the return up in the subclavian, and that creates a more natural flow pattern, not quite as bad on that essentially retrograde flow resistance. So that's another approach that's commonly used. So VA ECMO is a good tool. It works great for rescue therapy. But you can't just leave it when you're cannulated femoral. So let's say the heart does recover a little bit, and this patient now, instead of the one that had only cardiac, has also pulmonary problems. And their heart gets better. And now their heart's pumping really well. And you're cannulated down here, trying to pump up. You get this dual circulation phenomenon. The blood's going through the lungs. The lungs are trashed, not working. Deoxygenated blood goes to the left side pumps it out, nice and strong. It goes up, it meets the flow, you're coming this way, because remember, we can't change the volumes of the patient. And all of a sudden, from the diaphragm down, they have a PO2 of 500, and from the diaphragm up, they have a PO2 of 40. It's a big problem. Happens. I've seen it happen so many times, and it's frustrating. Because if you don't change the cannulation, you're done. Not going to be long. That patient's just not going to do well. It's not going to be a survivor, okay? So these are the kind of things we need to be thinking about when we do these procedures. These people, look, if you get ECMO, you don't need to go back to that first picture that I put of what y'all will look like when you hear patients going on ECMO. These are sick people, the sickest of the sick, period. Now, you can get them in the early stage of their sickest of the sick phase, or you can get them at the very end of their sickest of the sick phase. Outcomes aren't going to be too good, or somewhere in the middle. The earlier you intervene, the golden hour, time to reperfusion, same thing with ECMO. Sooner, and I'm going to show you some data on that. Sooner you get them on ECMO, the better off you're going to be. Basically, this just tells you the same thing. I don't want to belabor the point, but this shows you the blood being drained from there. I'm not sure what that is. I guess that's the pump. Yeah, that's the pump. Coming up here, that's bad one. I don't know what that is, huh? going into the oxygenator, and then they're cannulated up in the subclavian. So that's the subclavian approach. And you can also do variations of it. You could take a patient on VV ECMO and convert them to combined VV and VA. You can do that too. You can have VA ECMO and then convert them to just VV. And it takes a little bit of surgery, you know, and the surgeon needs to know what they're doing, but you can do that. This shows you that Avalon catheter that I showed you. It's kind of a diagram of it. I think this one shows you the same basic thing. I'm not going to spend the whole lot. I've already showed you. You got to have a C-arm to do it. Now, if you're really good, I've seen surgeons put it in without fluoro. They have put it in with TEE only. But man, these are some gifted guys. They're good. But C-arm makes it much easier to do. And the problem is, the reason why you want to use C-arm is you go stick this thing in the neck, and you got to get the wire down there. You need to confirm, absolutely certain the wire is in down by the liver. Because if it's not, this thing goes and it gets off track, and of course this tip then just perforates the right atrium, and usually it's over. It finishes up pretty quick. So those are quick cases. Okay. Mm-hmm. I'm really not trying to scare anybody here, okay? I'm trying to make y'all more comfortable. I don't know if I'm doing a good job of it, but I'm trying, okay? Categories of ECMO, we talked about that already. I'm sorry, I'm not following my slides too well today. I'm doing a terrible job of it. There's peripheral cannulation, veno. You have the basically femoral vein. Really, it's up towards the right atrium. It's a long cannula. It's even longer than this. It's about that long, and it goes in here and sticks. You know, goes up to about here. And then you have the femoral return. So that's peripheral cannulation. The other one was, remember I showed you access from the femoral vein to the right atrium, and then the subclavian. Kind of the same thing. Okay, so let's talk about anticoagulation management. So the Society of Critical Care Medicine probably has the most comprehensive data on how we should manage anticoagulation. I am very, 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 I'll say it one more time, very much against using ACTs for anticoagulation management. The reason for that is that their range of error is so much that you find yourself chasing a number and you're all over the map with your heparin drip and boluses and this and that. Even with the low-range ACT technology, an ACT of 150 can be an actual ACT of 130 or 180. And that's how much error you can have in those devices. If you were to do 4 in a row, you would have 4 completely different numbers. None of them would correlate with the one sample. The SCCM recommends using the PTT, the APTT, and it has on here 50 to 60, but it should read 1.5 times baseline. And when you first start it, you want to run that PTT maybe once every 4 hours, but once you're stable, once every 12 hours is really sufficient as long as you have the heparin running, you know that it's on a drip. I prefer, and this is a preference, if it's a little bit low, to just give a little bolus instead of going up on the drip, because you go up on the drip and then you check it again in another 8 hours and it ends up being too high and you turn the drip down. If I can get a steady state or pretty close to it and it's just drifted down, I'd just rather give a bolus and bump it up that way as opposed to continuing to go up and down on the drip. I think it's less labor intensive for you all. Obviously, you have to have some anticoagulation because there are areas, and you'll see the oxygenator later, there are areas around connectors, stopcocks, in the oxygenator itself where it's not necessarily good flow. There's just areas of stasis or sluggish flow around all these devices. And if you have inadequate anticoagulation and you have your flows real high, you can pretty much overcome it because the transit time through the system is short and it doesn't really have time to clot. However, you can develop consumptive coagulopathies that way just because you've got some activation and it keeps activating over time. So you want to make sure you do have adequate anticoagulation, but more importantly, these areas of stasis or sluggish flow, they will clot. And clot begets clot. That clot just seems to grow no matter what you do. It makes the area of stasis or sluggish flow get bigger and bigger, and then you're in a situation where your oxygenator is going to thrombose and you have to change it. It's one of those things that can happen if you completely just thrombose your circuit off, and the patient is totally dependent on the ECMO circuit. The patient is not going to make it. I mean, there's no way to change a circuit no matter what you do, even if you had another one right there next to you to do fast enough if they're completely dependent upon it. But there are things that we do that show us trends, and we know, okay, this oxygenator is starting to fail. We need to start thinking about changing it. I want to talk to you about that too, because there's some philosophical differences I have with a lot of my colleagues, and I want to discuss that with you guys. But consider flow. So when they're wanting to wean from ECMO and they barely have any heparin because, oh, we don't want the patient to bleed, and they want you to turn the flow down, well, you know, we can all figure that out. This is not a good idea. We can't do it this way. We've got to make sure that patient is anticoagulated well before we start turning the flow down. Temperature management, it's great. You'll see that. I don't think we have a heat exchanger, but you see that device right there where the oxygenator sits in with those two silver ports at the bottom. We have a heat exchanger that will always accompany an ECMO, which gets connected to it, and we can set the temperature to whatever you want that patient's temperature to be. So you want to do hypothermic protocol, you want the temperature to be 34.12 degrees, we'll make it that for you. So we can control the patient's temperature very precisely, change it incrementally very precisely. Now, that's an advantage. Disadvantage is we can mask a patient who may be febrile. We have the heater, we don't want the patient to get cold, so we have it set at 38 degrees, but the patient really wants to be 100 degrees because they've got an infection, and we're keeping them at 38 degrees. It may delay your ability to see that. You need to remember that. So a lot of things we do will mask other things. CRRT, we're going to talk about that here just a minute. CRRT masks a lot of problems, especially when you have great clearance. You're running it at high volume. Patient looks great. You know, the lactate level is only, 1.6 because you're clearing it so well. Turn this off and the lactate's 8. You got a big problem, and no one picked up on it because we hide those things by being so efficient. Coagulation management, okay, ECMO causes decreased platelet counts and function. We know that. ECMO depletes clotting factors. Well, a lot of it does, but a lot of things do too. Being sick depletes clotting factors, right? Having surgery and having been exsanguinated a few times in the operating room causes coagulopathy. ECMO certainly does contribute to it long term, but it's really not that horrific. Put somebody on ECMO, they're just not losing all of their clotting factors and all of their platelets and all of their hemolysis and so forth. These technologies that exist today that you're going to have here at this hospital, they've gotten really good. But the textbooks still say this, so you have to take that and pay attention to it. You do have inflammatory response that occurs. It's a foreign system. It's a foreign device. You do see some inflammatory mediator activation with it. Generally not that bad. It's much less with ECMO than it is with the full cardiopulmonary bypass circuit, but it does exist. Most of these patients, of course, have SIRS. They have systemic inflammatory response syndrome. They're already like that anyway, so we don't really make it that much worse, I don't believe. But why do oxygenators fail? Because that's probably going to be one of these big things that can happen, okay? All of this stuff is what it is. All I want you to focus on is this right here for right now. Propofol. Propofol is not, this is absolutely incorrect. It is not contraindicated in ECMO. It is contraindicated in ECMO with the circuit we use. There are two different kinds of circuits out there. So I was going to talk about this a little later, but I'm going to do it now. There are two different kinds of oxygenators out there. There's those made with polypropylene fibers, and polypropylene fibers, when they have high lipid contact them, change from being hydrophobic to being hydrophilic. Now, how you make these things is they take these fibers, and I'll show you a picture of them, and they stretch them, and they break the molecular bond so that the pore size is 700 angstroms. Well, that's only going to let gas go back and forth. That's pretty small. But when they fill with fluid, they react to the lipids and start to swell with fluid, that bond, that break, pore size gets bigger and bigger and bigger and bigger and bigger. And I'll show you a slide, a video of what that looks like. On the other hand, they have other oxygenators made of different fibers. And it's polymethylpentene, PMP. And those do not react as much, still some, but not as much, with lipids. And they are designed, because of that, to last longer. So you could imagine you're a lung transplant patient. You're going to get an ECMO. You're going to be walking up and down these halls waiting for your lung transplant, and we need to keep you exercised and healthy and all that kind of stuff as best we can. And your oxygenator is going to fail every couple of days because of your own lipids. Well, that's not good, or a week or 2 weeks or whatever it may be. You want that thing to last as long as you possibly can. But again, that's a different subset of patients. What do all of you do every 48 to 72 hours? You have a patient in the ICU on multiple drips. Every 40, what do? Change your lines. Change all your lines, right? And you do that for infection control. So this is the philosophical divide. I feel very strongly that if a patient is in here critically ill, and I'm going to leave a circuit on that patient for more than, we go longer than y'all, 5 or 7 days, which is about the life expectancy of our circuit, the poly, as long as you don't use propofol. Use propofol, it's going to be short. Not using propofol, it's going to last 5 to 7 days before you're going to need to change it. And I've done this for many, many years. Every time I change it, they always pink up a little bit, you know, for a period of time, and then sometimes they kind of go back to where they were. But do you want to leave a circuit like that I just explained to you has dead space areas, connectors, stopcocks, all of that stuff on a critically ill patient that is clearly at an infection risk, a greater infection risk? Do you want to leave that patient on that circuit with all that tubing that I showed you for 30 days? I don't. Now, some very smart people, my colleagues, would disagree with me, and we have fought tooth and nail about it, but I feel very strongly about it, and that's why we've chosen the direction that we have to use what we have. But with that said, it has a limitation. That limitation is don't use propofol. So when we get our first ECMO, one of you will be there. Run in the room and scream, do not use propofol. Okay. But other things happen to all oxygenators, and you do get inflammatory mediators that will stick to the fiber, to the membrane material and plug the holes, kind of like a CRT circuit does. Everybody, who here has used CRT? Who knows CRT? Good, all of y'all. So all of you understand that concept of absorbing those inflammatory mediators. That same thing happens with these oxygenator fibers. This says change out oxygenator every 3 to 5 days. I think that's, you know, it'd be nice, I think, every 3 days would make sense to me, 72 hours. But, you know, it is a dramatic event to some degree. Not that bad. It's not as bad as, you know, if you're planning it, it's acute when it becomes a problem. You know, that's when it's a problem. Like you walk by and you break a connector off and the blood's flowing everywhere, and you're just like you're just clamping lines. Well, that's different. But when you're planned, it actually, even if the patient is completely dependent upon the ECMO, what do you say, Jeff? It takes you how long? 30 seconds, 40 seconds?
Just less than that.
Less than a minute for us to change the oxygenator. But we do this a lot. And you're planned for it. So here's going to be a video of what happens. I want you to remember this video. I want you to have nightmares about this video when you use propofol with one of these oxygenators. This is a classic plasma leak. And when you have this, you've got to get the propofol off, because that's what happened. And you turn the propofol off and you change it.
That was every 8 hours.
Right. And you see the connections down here of the water lines that would be controlling the temperature. So this is what the fibers look like. Don't spend a whole lot of time on this. It's a hollow fiber. The technical term, it's really not a membrane. It is a hollow fiber microporous oxygenator. So it's not a true membrane because there are pores. If it was a true membrane, that couldn't happen, right? So don't worry about all this stuff here. Third spacing edema, acute renal failure, acute kidney injury. All of these things are inevitable. They are going to happen. In fact, they happen quite frequently on patients on ECMO. I'll show you again some data as I move forward with this. CRRT is going to be something we can incorporate into the circuit. I'll show you that here. And you can see the circuit, and you can see the CRRT circuit, the CRRT portion of it being connected to the circuit from an access and a return. We like to access the positive side and then return on the negative side. Some machines are better than others at being able to handle the hostile to them environment of the CRRT circuit. The pressure on the access line is going to be in the negative 80 range. The pressure on the positive side is going to be between 200 and 280 millimeters of mercury, and most of the technology that exists has a hard time being able to manage that because it's designed to be for a Maherka catheter and totally different pressures. I know some manufacturers have worked for having some software that can accommodate that. It asks you, if you're going to be on ECMO or if you're going to be on a positive pressure environment, whatever it uses, they ask you, and you select that in order for the machine to not just keep alarming. Some machines don't have it. I'm not sure what you all are going to use here. There's always little tricks that you can do. I don't like them because it involves hooking up stopcocks and turning them, slightly off, closing them a little bit to sort of modify the pressures. That's obviously going to be a place for turbulent flow and for resistance and increased hemolysis and whatever else happens to the blood when you do that. But it can be done. And some are easier than others. What are you going to use here? Does anybody know? Next stage. I mean, it's, at the risk of saying something controversial, it's my least favorite. I'll say it that way. But, again, if it won't work in the ECMO circuit, then they're going to have to just reconcile themselves to having to put in another line, a Maherka catheter somewhere. But we certainly will make every effort, try really hard to incorporate it in the circuit, because we don't want the patient getting another line either. You may have to look at, if it doesn't work, you might have to look at something else just for your ECMO patients, but we'll worry about that down the line. You haven't even had an ECMO patient yet, so let's try to figure that out later. Anyway, I'm a strong advocate of CRRT. I think that it is incredibly useful, especially in this patients. I don't think they ever use it at high enough clearances. I don't think their replacement rates are ever as high as I would like. But nevertheless, I think it has tremendous utility, especially for managing the third spacing, the edema, and controlling that and keeping these patients from, looking like, Jabba the Hutt or whatever they start to look like. Weaning. Weaning is always a challenge, it seems, with folks, but when you wean from VV ECMO, there is absolutely, now unless you had that cannula that was going to pulmonary artery and you look into the RV, but let's just leave that off of here and just stick with traditional, with this one, VV ECMO. Absolutely no reason in the world to turn the flow down. You can leave the flow up as high as you want. You can just simply turn the FiO2 down because, again, it's a closed loop system and you're no longer oxygenating the blood, then obviously, and their lungs must be doing it itself. You can even turn the sweep gas all the way down and turn it off. So you can wean those patients with just by controlling the sweep gas or tidal volume, if you will, and the FiO2, how much you're oxygenating that venous blood, right? If it is, and of course you have to adjust your ventilator, right? You can't just leave the ventilator turned way down and turn this down and expect it to be you have to make your adjustments. So the pressures are better, patient's looking better, x-ray looks better. Okay, we're gonna go up on the ventilator, we're gonna turn the FiO2 up from 40 to 60 maybe. We're gonna increase the tidal volume from 300 or 400 up to 600. They're looking better, pressures look better. And then you start weaning down your ECMO oxygenation portion and see how they look. If it's VA, then it's going to be a completely different situation. So if it's VA, remember what I told you, if you start turning the flow down, which you're going to have to do in VA, got to make sure they're oxygenated, but as you turn that flow down, and that heart starts to eject, those lungs need to be working because otherwise you're going to have the problem that I discussed earlier of parallel circuits in essence. But you just have to, to do VA, you have to turn the flow down, which means you've got to make sure the patient is appropriately anticoagulated at that point so you don't have the flow going so low that there's such a long transit time that you start creating little clots that you just keep pumping into the patient. They may not stay in the circuit and clot the circuits, you just may be literally pumping them to the patient. So you've got to be careful about that and cognizant of it. So let's talk about survival, because what are we doing this for? If everybody died, did you die? No. Then my patient satisfaction score should be 100%. Okay, thank you. Always appreciated applause, We're doing this because we want to save people's lives. We're not doing this just to save, 0.5%. So in this critical care resuscitation journal article in 2013, this is a meta-analysis of 12 different studies, including a total of 1,700 plus patients. Most of them were VA patients. They averaged a 30-day follow-up, with the range being 30 to 68 days, and they had a 54% mortality, which gives you about a 46% survival. It's not too bad when your survival is 0, right? Or your potential for death is 100%. 48% of the deaths of this 54%, 48% of them died while on ECMO. There's a whole bunch of reasons why we die on ECMO. Renal failure, 52%. Bacterial pneumonia and hemorrhage, 33%. Oxygenator failure was 29%. Now, that scares the hell out of me, because I'm going to tell you something right now. We are not going to have a 29% oxygenator failure rate here. I can assure you of that. If it happened once in 5 years, I'd be shocked. We just don't let that happen. At the end of the day, this becomes, that's our responsibility, and that's not something we ever want to have happen. So that seems really high to me, but like I told you earlier, there are some really smart people out there with some incredible ECMO programs. There's also some people out there that have ECMO programs. Won't criticize them, but I report, you decide. Sepsis, 26%. Hemolysis can be a problem. Liver dysfunction, and then leg ischemia and other issues were less. But you can take a look at those numbers. What's important about this study And what becomes controversial is even with, well, it's the next slide, but in this one, even with conditions usually associated with high chance of death, almost 50% of patients receiving ECMO survive up to discharge. Complications are frequent and most often compromise renal failure, pneumonia, sepsis, and bleeding. It's the next slide that's going to have a little controversy to it, because I love controversy. Okay, this goes on to show cannulation, same study, survival to discharge was 57%. No, I'm sorry, this is a different study, I apologize. Early initiation, different study, I apologize, of influenza and ARDS patients, and early intervention improved survival. The yellow stuff's what I want you to look at. Let me just do it this way. Survival to discharge was 57%, so a little bit higher than the other group. I mean, not that much higher, but a significant amount. Cannulation within 48 hours of admission was associated with a long-term survival of 80%. That's amazing. Compared to 50% if you cannulated between days 2 and 5 of admission, and only 29% if you waited 5 days after admission to go ahead and put the patient on ECMO. They go on in their conclusions, early initiation of ECMO is associated with increased long-term survival. So where's the controversy? Anybody? I'm going to ask anybody. If you get this right, Jeff is taking you to Trulux tonight. Does anybody know? Because that just sounds great. Where's the controversy?
ARDS doesn't show up till later.
That's a good thought. That's a good thought, but that's not quite the controversy I was looking for, but that's true. Anybody else?
It's not initiated. It's hardly initiated that early.
That's true, but not the controversy I'm looking for. But that's okay. Anybody else? Okay. So, I'm sitting at a meeting and somebody gets up there and shows me this slide and says, oh, when we put the patients on ECMO within 2 days of admission, we had an 80% survival. Somebody goes up to the microphone and says, they probably would have survived anyway. That's the controversy. What's too early? So, did the patient really need it? Could they have done without it? Did you do something that's tremendously invasive and could have potentially gotten away without it? Is that not too early? That's the dilemma. What is too early to avoid criticism? That will always be the Achilles heel of ECMO survival. Because if you put it in too early, people are going to say, what are you doing? Why'd you put that patient on ECMO? However, I would go full circle back to my first few slides. There are documented criteria that say if you meet this, you should consider it. At that point in time, it becomes a medical decision. But the data is the data. Can't argue with it. If you put it in sooner, you're more likely to survive. The longer you wait, the more likely you won't survive. And if you wait until the patient is deceased, you will have a deceased patient on ECMO. Don't do that. Want to talk about some financial stuff so that you guys can maybe grasp that a little bit. I don't want to spend a lot of time on it, but I think it's important. Everything on ECMO, which is DRG number 3, is based on 26 units or 25 days. The first day is considered 2 units. And this is 2014. You can see it's gone down from 2013 to 2014 and continues to go down because we're getting better at it. So the better we get at it, the less the government wants to pay for it. So this is on, obviously, Medicare patients. $157,210. That's what the hospital will get paid to put a patient on ECMO. Now, if the patient is in the cath lab and the patient has had 3 stents put in and something has happened, they had a massive MI, and they decided to put the patient on ECMO, they don't get that DRG. They don't get paid for the cath lab visit. They don't get paid for the stents. They don't get paid for any of that. It goes away for the higher DRG. So that's what you get. If you do heart surgery and we cannot wean the patient off of the pump, and we've been in the operating room for 14 hours, and we've used 20 units of blood and pack cells and platelets and FFP and cryo and whatever else goes on down there, we decide to put that patient on ECMO. The hospital loses that DRG payment and gets that. So you get the higher DRG, you don't get both. Patient hits the emergency room with full cardiopulmonary collapse. They put that patient on ECMO. They get that DRG. That's what you get.
Sorry.
Now, if the patient, you transfer the patient, oh, that's okay. I'm sorry too. If that patient, you transfer that patient, then you get your units. Depending on how long it's been, the receiving hospital will either start back at that DRG from day one, or they'll start somewhere later. So there's an incentive for the government to keep hospitals from putting the patient on ECMO, keeping them long enough to make it economically rewarding for them to do it, and then transferring them out and letting the other hospital take over the rest of it and get whatever they get. So the government de-incentivizes that by punishing the hospital financially depending on what they do or what happens with this patient. So it's not, it looks $157,000, sounds like a lot of money, but in 3 weeks, 4 weeks, it's gone. And that's all you get. Patient stays in your hospital for 6 weeks, 8 weeks, 10 weeks, 12 weeks, whatever it is, that doesn't matter. That's what you get. Some of the financial drivers, obviously, for ECMO, the equipment cost, it's expensive. The disposables are expensive. People like us are expensive. You guys are expensive. How much volume, the duration you have patients on ECMO, and the success or failure or the survival percentage versus the non-survival percentage being biased towards more survival are the things that will influence in a positive way what ends up happening with the hospital having to take care of these patients. If we all, we're all expensive, the hospital knows that, it's going to cost them a bunch of money to do this. But if we do it well, we work together as a team and focus on the patient, doing the best that we possibly can do, we get our docs to don't wait till the patient's dead, got to do this, or you've waited so long now statistically, and you can find all this data is available for anybody to be able to find, statistically the chances of this patient's survival is essentially zero. Why are we doing this? Or, come on, don't wait so long. Okay, good, let's do this and get this patient through this, get them better and get them off the ECMO in 3 or 4 days. That's the best of both worlds. There. The other is a real problem, if that's the direction. So educating your medical staff on patients that you see trending that way, they may not even think about it. Probably not a bad idea. The more you know about it, the better off your patients are going to be, because you're with them all the time. The docs just come in and out. Any questions? Thank you, by the way, very much.